Hello, everyone. Thank you for joining today's webinar, Options for Lowering Costs for the Privately Insured. I am Kate Sullivan-Hare, Vice President for Policy and Communications at the Alliance for Health Policy. For those who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. The Alliance for Health Policy, if I could have the next slide. The Alliance for Health Policy gratefully acknowledges Arnold Ventures for supporting today's webinar. The Alliance is pleased to have Hunter Kellett, Director of Payment Reform at Arnold Ventures, for some opening remarks. Hunter?
Thank you very much, Kate, and thank you to the entire Alliance team for their work to put together this event. I also want to thank today's speakers who are here to talk about a very important issue: how to lower costs for the over 160 million people with commercial health insurance. In polling from Pew last week, 56% of Americans said the affordability of healthcare is a very big problem in this country. Healthcare affordability ranked higher than immigration, higher than infrastructure, higher than any other policy that was listed. At Arnold Ventures, we're a philanthropy dedicated to tackling some of the nation's toughest problems with evidence-based solutions. Whether it be criminal justice reform or healthcare, we support critical research to better identify the problem and drivers of high healthcare costs, and then use this research to inform policy for both state and federal policymakers. When it comes to healthcare affordability, one area of focus for us are the prices that commercial insurers pay providers, which on average are 2 times what Medicare would pay for the same inpatient hospital service. Today's session will talk broadly about the commercial market. Not only those who receive health insurance through the marketplace, but also those who are much more likely to receive health insurance from their employer. We hope you walk away from today's session with a good sense of the policy options in this space, including how to think about markets where there's a lack of competition, and in particular, how to address the underlying problem of prices. Lastly, as new options emerge in the debate on affordability, we hope you'll have a better sense of how options will affect different actors, including insurers, hospitals, and clinicians, but also employers who pay a large share of the premium costs, individuals and families or consumers who pay their share of premiums, deductibles, co-pays, and co-insurance, and lastly, the taxpayer who subsidizes the commercial market through the tax code. I hope you find this session informative to your work. Thank you very much.
Great, thank you so much, Hunter. Now we'll go over some quick housekeeping items and then introduce our moderator and panelists. I want to remind everyone that you can join today's conversation on Twitter using the hashtag AllHealthLive and join our community at All Health Policy as well as on Facebook and LinkedIn. We want you all to be active participants, so please get your questions ready. If I could have the next slide. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that icon to submit questions that you have for the panelists at any time. We will collect these and address them during the broadcast. You can also chat any technical issues that you may be experiencing, and someone will attempt to help. If I could have the next slide. Please be sure to check our website, allhealthpolicy.org, where you can find background materials, including a resource list and an expert list. A recording of today's webinar, including today's slide deck, will be made available on our website soon. And today, I'm so pleased to be joined by an esteemed group of experts. If I could have the next slide. First, we have Dr. John Holohan, who is an Institute Fellow at the Health Policy Center of the Urban Institute, where he previously served as Center Director for over 30 years. John examines the coverage, costs, and economic impact of policies like the Affordable Care Act, including the costs of Medicaid expansion, as well as macroeconomic effects of the law. And his expertise has been leveraged to testify before congressional committees. Thank you for being here, John. Next, I'm pleased to introduce Mr. Avik Roy, President of the Foundation for Research on Equal Opportunity, a nonpartisan, nonprofit think tank that conducts original research on expanding opportunities to those who least have it. He also serves on the advisory board of the National Institute for Healthcare Management. He is a senior advisor to the Bipartisan Policy Center, and he co-chaired the Fixing Veterans Healthcare Policy Task Force. Avik, welcome, and it's great to have you back. Next, I'm pleased to introduce Mr. Fred Bentley, Managing Director of the Center for Healthcare Transformation at Avalier Health. As an expert in fields ranging from payer strategy to hospital-physician alignment and post-acute care, Fred has worked with providers, including integrated delivery networks, academic medical centers, post-acute providers, and long-term care organizations, as well as national and regional health plans. It's a pleasure to have you with us today, Fred. And finally, we have Ms. Emily Stewart, Executive Director of Community Catalyst. In this role, Emily oversees the overall direction of Community Catalyst work to empower the consumer voice in health and healthcare decision-making. Most recently, Emily served as the Vice President of Public Policy for Planned Parenthood Federation of America and Planned Parenthood Action Fund. So pleased you could join us, Emily. We're going to launch today's discussion, and we're beginning to hear from John. And I'm going to ask all of our speakers if we could turn off our camera so that we can all focus on our speaker. John?
Yes. Okay. So can you hear me?
Yes, John, you sound great.
Yes, we can hear you.
Okay, good. All right. So we're ready to start?
Yes, John, please go ahead.
Okay. Somebody could you put up the first slide then? Okay. So I just wanted to start with a word about the competition versus regulation debate. And just say that there's clear evidence that competition can work in the right circumstances. And the example I'll give is the marketplaces where subsidies are tied to second lowest cost plan. If you want a more expensive plan, you have to pay the full cost. This has provided strong incentives to keep premiums down. So in our analyses, we found that markets with 5 or more insurers and low hospital concentration have premiums that are about 35% lower than markets with 1 insurer. The problem is that a large number of insurer and hospital markets are very concentrated. For example, 40% of rating regions in the ACA in the non-group market have 1 or 2 insurers, and about half of a hospital market in these rating regions are also concentrated by FTC standards. So concentration means payment rates of providers are higher as a result. The next slide provides some of the evidence on this, that showing the ratio of private insurance prices relative to Medicare prices from various studies. The first one in the top left is work that we did, and the average ratio is of private prices is 2.4 times Medicare. In other words, 240% of Medicare for hospital care. Another study found exactly the same. Inpatient ratios are a little bit lower, around 2. Outpatient care is higher. Physician services completely or quite a bit lower. The next slide. So this is what, with these high payment rates to providers, this leads to high premiums, and that leads to the interest in the public option or capping rates to offset the effects of the concentration. Public option is a government-run program that provides insurance. It bears the risk. It can contract out for administrative services. It can be implemented in the non-group market alone or in both the non-group and employer markets. We generally set payment rates below commercial rates, either at Medicare levels or Medicare plus something. The public option would generally be the benchmark premium and affect coverage and government subsidy costs. If it applies to the employer market, it will also affect employer and household spending. It could reduce the participation of private insurers who might find it harder to compete with a public option, but it could also give private insurers considerably more leverage to negotiate rates with providers. The next slide, please. So a variant on this is capping rates, and this would limit rates paid by all insurers at Medicare and Medicare plus something levels. This is pretty much like the way Medicare Advantage works in the Medicare program. It can be implemented in non-group and employer markets. it could be combined with the public option, again, like Medicare Advantage. Individuals would benefit from lower premiums while keeping their private insurance, and more insurers can enter and exit in market than with the public option alone. The next slide, we completed, with the support of Arnold Ventures, a number of studies recently. These are probably the key findings. There's a potentially significant effect on premiums in the non-group market, as high as 28%, depending on where you set payment rates. But the effects are small in the aggregate or nationally because the non-group market is so small. You really change the game quite a bit if a public option or cap rate policy is extended to the employer market, which is about 10 times larger than the non-group market. Second, the lower provider payment rates are, the lower premiums will be, and the more savings to households, employers, and government. But here's the issue: that it'll mean a greater reduction in provider revenues, possibly more disruption, more political resistance. Capture rates result in more savings than the public option alone because the payment rate reductions are applied more broadly. We also looked at what if you exempt rural areas from the policy, and found that you could do that without much effect on national results. And lastly, the policies could be limited to highly concentrated insurance and hospital markets and achieve substantial effects on federal spending and national health spending. And this happens because so many markets are concentrated, and this is where premiums are higher. So even if you focus just on concentrated markets, you're going to have significant effects. The next slide. This sort of summarizes some of the results from one of the recent papers. It shows the overall effect on national health spending. If the policy applies in the non-group market, the effects are pretty small, as I said. These are largely savings in government subsidy costs because you're bringing benchmark premiums down somewhat. You're bringing down more in public option 1 because provider payment rates are lower. The next 4 extend public option or capped rates to the employer market, and you can see that the effects are substantially greater, ranging from 3 to 7% of national health spending if the public option applies to the employer as well as the non-group market. The difference is how low provider payment rates are set. And then capture rates, because they apply so broadly that all insurers use these rates, you get really significant reduction in national health spending. But the 16% only happens if provider payment rates are set relatively low, somewhat above Medicare, but not at Medicare levels. So the bottom line then, I think, is that the potential is significant to offset the effects of concentration using either one of these approaches. The downside is that the savings translate to lower provider revenues. So how much can be done without disruption and some adverse consequences is really kind of hard to know. It does suggest if policies are spread broadly and include the employer market, that some kind of a phase-in of the policy and the lower payment rates is going to be required. So I'll stop with that.
Sorry, everyone. We have a mic issue. We're trying to get Kate unmuted, but
Great, thank you so much. I'm so sorry for my audio troubles. Thank you for that helpful context, John. And now I'm going to turn it over to Ovik Roy. Rovik, if you could join us on camera. And we'll get you started with your presentation. Great, thank you.
Everybody, good to be with you again. I'm going to focus the bulk of my remarks on sort of the background of the problem. If we could click on my first kind of cover slide. The background of the problem being that monopoly power is a big problem in the affordability of healthcare. And if we want a solution to monopoly power, we can go one of two ways, right? You can have the monopoly of the government or the monopsony of the government dictate prices, which is one approach, or you can incentivize competition wherever possible. And I'm a person who leans towards the latter solution, again, whenever possible. It may not be possible in every single situation, but we should certainly be aware of where the government has incentivized consolidation and what to do about it. So I'm going to lay out some of the data in these remarks, and then we can talk about solutions maybe more in the Q&A. Next slide. So just to give a little bit of background on the Foundation for Research on Equal Opportunity, or FREOP, for those of you who aren't familiar with it, our whole approach to public policy is we try to find ideas that are both progressive and free market oriented in nature. We work on free market solutions that increase economic equality by meaningfully improving the lives of Americans whose incomes or wealth are below the US median. Next slide, or click twice and you'll see the next several bullets there. We're a standard 501c3 think tank, and we work with both Democrats and Republicans. Click. And then next slide, please. So this is and click on the next one. This is a slide about national health expenditures and private insurance premiums. So many of you are familiar with the official CMS data on national health expenditures. What I'm trying to highlight in the right donut chart is that private insurance premiums and what private insurance premiums pay for is different from what national health expenditures overall pays for. And that's really important, because the conversation about the public option, Medicare for all, et cetera, is about what to do about the people who have private insurance, which is to say the non-elderly population. And when it comes to the non-elderly population, you notice a couple big differences, right? One, prescription drugs is a bigger portion of the pie in terms of private insured population and their spending, and physician services as well, along with hospital care, which is obviously important across all demographics and payer groups. Next slide. A big problem is that the hospital care in particular, and this is it's true to a lesser degree with physician care and prescription drugs, but hospital care overall is a huge problem. What you're seeing on this chart is for the median households. The median household makes about $60,000 in America. What percentage of their income is going to the IRS every year? It's declined somewhat thanks to the Tax Cut and Jobs Act of 2017, and it's leveled out in the sort of 13.5% range. Click. Now what you're going to see next is the share of national income that goes to the hospital industry. We're now at a point, and I had to triple check this spreadsheet to make sure I wasn't miscalculating this. We're now at a point where the average household is sending more of their household income to the hospital industry than they are to the Treasury Department. That is how bad the problem has become in terms of the affordability of hospital care. And that's before you even get to drugs, doctors, and everything else we spend on healthcare. This is just the hospital industry. So this gives you a sense of the severity of the problem. Cutting taxes for the average family is no longer material to their living standards relative to the rising cost of healthcare, particularly for the privately insured. Next slide. And a big problem here, and click through the next two clicks here to see all the curves. What you're going to see here is that adjusted for inflation, what Medicaid and Medicare pay hospitals has stayed relatively constant, but what private insurers are charged by hospitals has skyrocketed. And this chart is actually 9-year-old data. It's gotten even worse over the last 9 years. We're now at a point, based on various research that's been done by a number of people who are familiar to this audience, that the average hospital privately insured patient is basically being charged 3x what a Medicare patient is being charged for the same service, the same unit of care. That is not sustainable, right? And so you hear this argument that, well, hospitals are cost shifting the cost of the care to the privately insured patients. That's not true. What's happening is wherever hospitals can charge more, they are, which is to the privately insured, and where they can't, because of administered prices, prices have basically tracked inflation. Next slide. So here is one way to capture how much monopoly power and consolidation has driven this problem. And I could show you a lot of slides. I have a whole talk on hospital consolidation, how damaging the massive trend towards these massive hospital systems that have become regional monopolies is. I'm going to capture it with this one particular study from Jamie Robinson at the UC Berkeley. He looked at basically dividing the country into two buckets. One half of the country is in a relatively more consolidated or competitive market for hospitals, and one half of the country that's like more consolidated than average. So the blue bars here are the more competitive markets relative to the average, and you see the average prices of various services and the average underlying cost of those services, and then click. And here you see in consolidated markets what hospitals are charging. You see the underlying cost of delivering those services is basically the same. In fact, in the competitive markets, there's a little bit more efficiency on the cost side. But the prices in the consolidated markets is higher. And this is like an open secret in the industry. Everybody knows that the whole point of merging hospital systems or individual hospitals is to charge higher prices. That's the only reason to do it. And yet our regulatory system has been incredibly permissive for allowing these mergers to continue. Next slide. Now I'm going to switch gears to drugs. The same phenomenon in a different way applies to drugs. So a lot of people complain about prescription drug prices, as you all know. But what's interesting is for the part of our pharmaceutical market that is about small molecule medications, that is to say, drugs that are like conventional pills and relatively simple drugs to manufacture that represent 99.6% of all prescriptions in the United States, the vast majority. We actually do a really good job of steering people to low-cost generic alternatives. We actually lead the world in terms of unbranded generics being substituted for branded products where appropriate. 79% as of 2018 compared to 29% for the European Union on average. But here's the problem. Next slide. The problem is that the spending on prescription drugs isn't entirely on that 99.6% of drugs that are small molecules. So small molecule spending, and these are nominal dollars, meaning this is not adjusted for inflation. On a nominal, non-inflation adjusted basis, we've seen a decline actually in small molecule spending on drugs, net of rebates and without including inflation since 2015, which means on an inflation adjusted basis, it's even more a steeper decline, right? So, but why aren't we seeing headlines about the fact that prescription drug spending is down? Click. It's because for the 0.4% of prescriptions that are for biologic medications, the newfangled drugs largely manufactured by the biotech industry, we're seeing a massive growth in spending. We're now at a point where in 2021, we're going to see more spending net of rebates on biologic drugs than we see on small molecules, even though biologic drugs represent 0.4% of all prescription volume in the United States. Think about that. Half of all spending net of rebates is on 0.4% of the prescription volume in the United States. Why is that? It's because biologic drugs are not governed by the same laws as small molecules. Small molecules and generic competition for small molecules is governed by the Hatch-Waxman Act of 1984, which is an incredibly sophisticated and successful law reform that enabled a lot of generic competition. By contrast, biologic competition is governed by the Biologics Price Competition and Innovation Act of 2009, which is Title VII of the Affordable Care Act, or Obamacare. That law was heavily influenced by the pharmaceutical and biotech lobbies, which were very smart, which were very sophisticated, learned a lot from Hatch-Waxman, and did a lot of things to gum up the works such that competition really hasn't successfully emerged for biologic drugs. So these are two areas, just to sum up, where we've got to do a much better job at improving competition: hospital consolidation and competition, and biologic drugs. And we've written a lot on both topics. I'll point you to two pieces of legislation that attempt to address this in some of the ways that we at FreeUp have proposed. One is the Hospital Competition Act, which is sponsored by Jim Banks of Indiana, a congressman who's now the new chair of the Republican Study Committee. and the Fair Care Act of 2020, which is sponsored in the Senate by Senator Mike Braun of Indiana and in the House by Bruce Westerman of Arkansas. With that, I will stop and return for the Q&A. Thank you.
Great, thank you so much. Thank you so much for that, Vic. That was really terrific. And I'd now like to turn this over to Fred. Thank you very much.
Excellent, and thank you everybody for this session and for participating. Really looking forward to the Q&A. But just in terms of setting a little more context and maybe a slightly different perspective. So I work at Avalier Health. For those of you not familiar with Avalier, we're a DC-based research, consulting, and analytics company. We work with every part of the healthcare industry, helping them understand what's going on at CMS, what's going on the Hill, and what that means for their business strategy. And I, as my bio, as Kate noted in my bio, I focus on hospitals, health systems, physician groups. So I'm going to give you the provider perspective, and more specifically, what I'd want to touch on, rather than delving into the details of different policy options, is really give you a sense for, based on my work with organizations that really do kind of span the provider spectrum or continuum, what is driving real change? And I think it's here again, something we can come back to in the conversation, but at the risk of sounding glib, it's really not that hard to clamp down on costs, right? There are varying ways to do that, some subtle, some not so subtle. But what I want to focus on is really what is driving systemic change in how hospitals, physician groups, others are delivering care, and more specifically, delivering higher value care that is, yes, more affordable, absolutely important, but is also accessible and is high quality. And it's the triple, quadruple, quintuple aim, whatever we want to call it. That's what I want to look at and think about what's working, what's not, what is really driving meaningful change on the provider side. So if you'll move to the next slide, I want to touch on a couple of recent changes that I think both are on the competitive end as well as the kind of more heavily regulated sort of government focused approaches, and give you my sense, again, from the perspective of providers, from hospitals, health systems, physician groups, kind of what's the take here, what's actually going to move the needle in terms of affordability, as well as other things that we value around access and quality. Very quickly here, one of the areas that's gotten a lot of attention, and it's kind of a holdover from the waning days of the Trump administration, is the push for greater price transparency, specifically amongst hospitals. The quick take here, so for those of you not familiar, this is a new requirement that hospitals are supposed to be reporting on the negotiated rates, so the rates they negotiated with commercial insurers on up to 300 different procedures, and it's supposed to be available to consumers and to dorky researchers like me at the touch of a stroke of a few buttons. A couple of quick just observations on this. It absolutely, transparency is shedding a light on what we note here is arguably unwarranted variation in prices, and that is a big issue, no doubt about it. And you just look at some of the interesting data that the Kaiser Family Foundation just reported on a couple of weeks ago when they looked at this, looking at prices for MRIs. So you couple the fact that, yes, there's now a spotlight on this with a couple of realities. In fact, one is that the requirement as of right now really doesn't have teeth to it. So the data along the bottom, and I realize it's hard to read. You can see it when we share the materials if you don't have them already. A very small percentage of hospitals are actually making the rates available. They just decided they're going to take the penalty and not share those rates. So very hard to actually get that data out there. However, even if it gets out there, I think Ovic's point, as well as John's point around the underlying market concentration issues, market power dynamics, transparency is not going to change that. There'll be a recalibration of pricing, and payers and providers will work together and hash this out. There's as much of a chance of rates going up as going down, right? Once these rates are out on the table, and folks who feel like they got short shrift in rates will be going to payers and saying, I demand more. And again, at the end of the day, those hospitals and health systems, provider groups that have market power, have a monopoly, are going to leverage that clout, and they're going to continue to extract higher prices. So this is necessary, but by far from being sufficient to really improve affordability. Next slide. You know, a big area that I've been focused on for the better part of a decade, and where a lot of the discussion has been, is this idea around moving towards value-based care and the kind of cliched proverbial shift from volume to value that we've all been hearing about. The quick take there, and it's painful for me to do this, but for the sake of brevity, you know, there have been some meaningful gains. I do think this is causing that, or creating that fundamental change in how care is being delivered. It's too little, too late, arguably. And for the purposes of today's session, we're really focused on affordability for the privately insured. And so the big takeaway here is, yes, we're seeing ACOs cropping up. We're seeing bundle payment arrangements. We're seeing more risk-based arrangements, and capitation has made a pretty significant return. It's no longer a curse word. And yet the savings that have been achieved there, I think very few of them have really flowed through to the individual, to the consumer, to the employer. So it's a long, steady change. And you know, I think that's the reality with value-based care, is this is going to, you know, this is a decades-long change. And yet, you know, privately insured folks, Ovik, as he pointed out, who are really struggling with high costs, they don't have time for this steady incremental change. So that brings us to this next slide, and a couple of other realities I want to touch on before I wrap up here. You know, as we're talking about the public options and capped provider payment rates, some of the policy options that are being talked about now that Biden is in power and his team has come in, and it's there's been renewed focus there. A couple of realities I just want to reinforce. I think John and Ovik did a nice job, but just to give my take on it, the reality here is that you know, when you look at, as we show here, this is just a snapshot of, you know, typical hospital sort of revenue source, or what we call payer mix. And you can see Medicare and Medicaid are the big payers here. Commercially insured patients are also critically important. The key thing I want to emphasize, though, it's in that little box on the top right, is that of that commercially insured payer mix, only a very small subset of that are the non-group individually insured, or folks with individual plans, including individuals in the exchange or marketplace, you know, the Obamacare plans. And so any change there in terms of capping rates or grinding down on reimbursements, reimbursement rates, it's going to have a pretty incremental, if I would say trivial, impact on systemic change at the provider level. Now, again, maybe that's okay, and maybe the reality is, like, we want to cap rates, and it's also the reality that the rates being paid to hospitals and health systems and physician groups through the existing exchange plans are anything but, you know, basically matching Medicare rates. They're not significantly higher. And so that's a reality hospitals are already dealing with. So going to capped rates, going to, you know, this public option model, they'd have concerns about it. Yes, it would put a dent in their margins, but nothing big. The big deal, and where you really start to get their attention, as John indicated, is when you start talking about making changes to the employer, the, you know, self-insured employer coverage, the large group employer plans, those that are still buying, you know, traditional health insurance. If those capped rates did move to that market, or some sort of public option, as some states are starting to move towards, or starting to kind of dabble in, that is a big deal. That is a game changer, and that really does fundamentally shift hospital, health system, physician group economics in a meaningful way. So again, if we just focus on changes in the non-group individual market, you know, providers are going to say, okay, you know, we're not big fans of that, but you know what, we're already, you know, in a rate setting environment in Medicare and Medicaid, and for all intents and purposes on the exchange plans. So not a big deal. Very different story if we talk about the employer space, or moving to the employer market. Let's go ahead and skip the next slide just for the sake of time. There's just a couple of examples there of states that are moving forward in public option and capped rate models. But I do want to circle back to the proverbial cost shifting or sort of cross subsidization issue that Ovik touched on, and that is, we can have a discussion around whether it's a myth or not. I mean, the reality is that it is happening. So I don't think it's a myth from that standpoint, but I think there is a valid question around, as we show here, the payment to cost ratios. This is some data from the American Hospital Association, which just underscores that as Medicare and Medicaid rates have really held steady, and that ties in with the data that Ovik was showing. When you control for inflation, that the rates and on the commercial side have steadily increased. Absolutely, if we move to a model where we're rate setting and it applies to employer-based or some employer-based plans, if we take dramatic steps there will be cost shifting pressures. And again, we can debate whether that's or actually, I suppose it's not a debate. That's arguably not a good thing, but it will happen. And hospitals in particular will look for the employers, for the markets where they can extract higher rates. And again, reinforcing what's been said, in those markets where there's not a lot of competition, where there's high concentration, where they've got the market power, they're going to extract those rates. And so I think that's just a reality that, we squeeze one end of the balloon, the other part is going to pop up. Another thing that I do want to touch on, because it's almost kind of counterintuitive, but if we move to the final slide that I've got here, the reality is, like, if we are grinding down, if we're going to really cap rates, and we're going to cut that across not only the non-group market, but to broader employer coverage, whether it's through public option or some true kind of capped provider payment model, I would argue that you're actually creating even more of an incentive for both vertical and horizontal integration in the hospital and health system industry, the integration between hospitals and the acquisition, as we show here, which has continued to increase of hospitals acquiring physician groups. And that, the rationale is pretty straightforward. It's, if you are making the economics more challenging, particularly for physician groups and smaller physician groups that don't have the financial wherewithal to deal with caps on their rates, they're going to go to the health systems. And that is exactly what we've seen when Medicare starts to really clamp down on rates. In states where Medicaid rates have really dropped, providers have said, if I want to keep my doors open, I need to jump in with a bigger hospital or health system. And so that's another trend that we are unintended consequence that we have to deal with here, and it's a reality if we're going to move forward with some of these models. So look forward to your questions and the discussion, but I'll turn it back over for additional commentary.
Thank you so much, Fred. That was really terrific. Very helpful understanding the impact of various proposals. And now I would like to turn it over to Emily. Emily?
All right, just confirming you can hear me?
Yes, we can.
Okay, all right, thank you so much. Great to be here. And you can move to the next slide, I believe. Okay. So Community Catalyst, we're a national health advocacy organization. We've been around for 20 years, and our calling card is working with local, state, and national organizations to make sure that people's perspectives and experiences are rooted in these discussions, and that people have control over the decisions that impact their health. We firmly believe that we will not have a health system that is accountable to people without people's voices, perspectives at the table and influencing the decisions like these, and also truly believe that if we don't have an accountable healthcare system, we don't have health in our country, which is why I'm so delighted to be in this conversation today to talk about this important issue. And you can move it to the next slide. So I wanted to take a step back real quickly here to probably state a little bit of the obvious in terms of where Community Catalyst is coming from. And I think, as you all know, I'm here to talk about how proposals designed to lower cost will impact people and families. But before I did that, I did want to kind of reflect on a bigger picture point about what works in terms of policymaking, which is the importance of keeping a laser focus on continuously engaging people in the cycle of policymaking. It's obviously a pretty simple and straightforward concept, and certainly we've all been in conversations and read papers about things like patient-centered care and human-centered design and the like, but it's actually pretty common in the policy development process that too many assumptions are made about what really matters to people, what they are really experiencing, and what their priorities are. Oftentimes are often relying on data sets that are too often incomplete, particularly with respect to the experiences of people of color, people with low incomes, people with disabilities, women, LGBTQ+ people. So I wanted to raise this in the context of this discussion because obviously there are lots of different types of healthcare costs for people, and just really wanted to name quite explicitly that it's really important in any policy development process that there's a lot of attention focused on which of those healthcare costs need to be reduced the most for people, particularly for people who are most hurt by the system today. And you can take it to the next slide. And in the vein of stating obvious things, I also wanted to state that, remind folks in terms of taking a step back around people's experience that healthcare is obviously not affordable in this country. And there's a couple of headlines here on the slide, just relaying various studies that continuously come out about the ways in which people in this country are struggling to afford healthcare. And there's a few points on this that I wanted to emphasize. The first is that this is getting worse for people, which is no doubt why it consistently tops the list every election cycle in terms of issues that are most concerning to American voters. In fact, according to a Kaiser Family Foundation study, when you ask people about what's the most important feature in their health plan with respect to employer coverage, people say are now twice as likely to cite cost over coverage protections or considerations. And that is the exact opposite today as it was 15 years ago. That same Kaiser Family Foundation study put it at 50% of people in this country who are wrestling with some kind of healthcare cost. 1/3 of insured adults said it's very difficult or somewhat difficult for them to afford to pay their deductible. And I do think it's worth noting that that figure is 60% in terms of overall healthcare costs for people who are uninsured. 60% of uninsured people are skipping medical cost due to cost. So I actually put at the bottom of this slide a picture of a bill I just received because I wanted to also note that I think there's a lot of people who maybe say they don't worry about it and they say that they don't worry about it because it hasn't hit them yet. And you could probably have counted me as one of those people a couple of weeks ago, but I had a pretty, simple outpatient procedure the other month that was supposed to be covered with the exception of a small copay by my health insurer. And I just recently got a $1,349.49 bill from my hospital. And worth noting that it has been very difficult for me as somebody who works in health advocacy to kind of figure out where that's coming from. How am I supposed to pay for it? Reconciling between the hospital and the plan. Importantly, according to a Kaiser study, 1/3 of people with employer-sponsored coverage said that they couldn't afford a bill over $500. Again, I do want to reinforce that the data around cost is insufficient when it comes to understanding experiences based on race and other demographic factors. So it's really essential, again, that we're thinking about equity in the context of this conversation. And you can take it to the next slide. Okay. So what has helped? Coverage expansions, of course, the availability of the marketplace plans on the private insurance side and the Medicaid expansion on the public insurance side has contributed significantly for people who are uninsured, cutting the uninsurance rate in half. that has disproportionately helped people of color, Black Americans and Latinos in this country gaining important access to coverage. Still, there are major gaps with 30 million people remaining uninsured. About half of those are people of color. I also just wanted to, of course, point out that coverage expansions in the past, at least with the Affordable Care Act, have created a platform to address cost issues and making healthcare and coverage more affordable for people. In the Affordable Care Act, this was essentially, I think, ultimately the most successful and long-lasting aspect of the Affordable Care Act was the financial assistance of the ACA. So about 86% of people on the marketplace are getting access to tax credits under the Affordable Care Act, and 50% of people are getting cost sharing reduction support. So this has been a major benefit to millions of people. It's important to note that the American Rescue Plan Act has actually enhanced that financial assistance, but only for 2 years. But super exciting that now individuals with incomes below 150% of the federal poverty, for instance, will pay zero on their income for their premium. So that is great news, and it's important that those protections get extended and made permanent. Also, the American Rescue Plan Act did make those tax credits now available to people with incomes above 400% of FPL, which was one of the things I think what we came to understand is one of the big gaps of the Affordable Care Act. Also, limits on out-of-pocket spending. So for 2021, this is also under the Affordable Care Act. There's a maximum of $8,550 for an individual and $17,000 for families for out-of-pocket spending. As you can imagine, when you think about that in the context of income inequality, that's not so great for people who are making lower incomes. I did want to give a shout out in particular on the limits of out-of-pocket spending to the preventive benefit under the Affordable Care Act, which made cost sharing, which required no cost sharing for certain preventive benefits under the Affordable Care Act, which I think from an access standpoint is one of the provisions that translated the most in terms of eliminating costs and now demonstrating that people have better access to care. In particular, I think actually one of the most important and explicit protections in terms of the preventive benefit was the birth control benefit. And an example of how skeptical Americans are that any of this is really going to be resolved. I have 3 sisters, and when the news broke that the Obama administration was requiring health insurance plans to cover birth control at no copay, I heard independently from each one of them, both expressing happiness that this was a benefit for some people and expressing deep skepticism that they would actually experience it. But that benefit did go far and wide, reaching 60 million people. And we have some really good data in the system about the difference that it made. In that first year, the IMS released data showing that there was a 10% increase in the number of birth control prescriptions that were being doled out by pharmacies. And there's been a tremendous amount of research showing that utilization of longer acting methods increased because that was a method that was most cost prohibitive for many people. Importantly, wraparound support has helped in terms of making sure that people have support like the Navigator program under the ACA to understand what their benefits are, what their protections are, and in particular, there are programs, CAP programs that have been in existence and continue to be in existence that do help people resolve things like surprise billing. That kind of wraparound support really is essential to making sure that, number one, people can get enrolled in coverage. They understand what the financial implications of coverage are. They're getting access to financial assistance. And when they are, getting a surprise bill or otherwise facing costs that they shouldn't be from a health plan, it's really essential that they have that kind of support. And that investment in that kind of wraparound support, navigators, consumer assistance programs, SHIPs under the Medicare program, we need more investment in that. Overall, I would just say that the ACA is probably most instructive on one thing, which is that if the question is, whether or not competition among ACA marketplace plans affected affordability, the answer is no, it didn't. The thinking and the hope at the time was that you would create all this competition, premiums would be reduced enough that people who are younger and healthier would be flooding into the market, and that really didn't happen. If you don't have access to financial assistance, the fundamental truth is, and reflective of that, 15% of people who are in the marketplace, the plans are still too expensive for people to be attracted to buying coverage. And you can take it to the next slide. What's missing? It's really important that no matter what we do, we are putting equity at the center of the conversation, and thinking in particular about the people who are hurt most by the health system today, who are most excluded from quality care and experience within the health system today, and really resolving the cost question through their eyes. So that is people of color, people with low incomes, people with disabilities, older adults, and then also people who might fit both of those categories, like dually eligible folks. From a system-wide approach perspective, I think building on some of my previous presenters, just want to highlight that, it's really important to look at this through the view of who is delivering care today, what are they getting paid, who are they servicing, and who is paying them. So for instance, if you have hospital systems and health plans hospital systems and provider networks that are predominantly serving low-income communities, or who have a revenue stream that is predominantly a public payer versus private payer, or who don't have sufficient assets, it really is important that we're thinking carefully about the downstream impact of any policy proposal. And I think this is particularly important in the context of setting provider rates for public plans. This is not, quite aligned in terms of this issue, but I do think that the payments that came out of the stimulus packages towards hospital systems are instructive, whereby a lot of hospitals that really didn't need the support and actually weren't really seeing a ton of people with COVID-19 got a tremendous amount of payments from the federal government in terms of bolstering their revenue, whereas many hospitals that were serving predominantly Medicaid covered people, serving low-income communities, and who were overwhelmed with COVID-19 patients were not getting the support that they needed. So really thinking carefully about what the downstream impact is going to be in terms of any proposal is really essential. I did want to make one note here on the consolidation issue, since that came up, which is, I think the data is consistently showing that consolidation is increasing cost, not achieving the quality that is promised. I also want to point out that there's for certain patient populations, it is also reducing their access to care. So for instance, in some consolidation efforts, reproductive health care is being restricted, or healthcare for LGBTQ+ people is being restricted as a result of that consolidation. And so from a consumer standpoint, the regulatory apparatus that has been in place historically, I think was insufficient historically, and is especially insufficient in the context of the rising consolidation we're seeing, both with respect to hospital systems and, as was pointed out, with physician outpatient networks, but also in terms of retail settings, which I think we also need to take a careful and close look at in terms of impact on cost and quality of care. And finally, I just want to say the policy evolution is important. The Affordable Care Act is probably a good example of a situation where a big law was passed and then everybody was ready to just watch it change the world. And obviously it didn't, and it certainly didn't with respect to cost. Many people were helped. It was very, very important and continues to be an important and helpful law, but obviously there's a tremendous amount more to be done. And with that, I will turn it back over.
Thank you so much, Emily. And I'm going to ask you to stay on camera and ask all of our panelists to join us back on camera so that we can turn this over to our audience who has not been shy in feeding us questions already. I look forward to a really good discussion here. And we still have John Holohan on the phone joining us as well. But the first question I'd like to ask is one actually directed to Fred. Fred, you spoke about how mechanisms like market competition, rate setting, and transparency impact providers. Could you speak to some of the challenges and realities that payers are facing within this policy discussion?
Sure, happy to. So specifically, for some of the specific policy mechanisms and options we've been talking about, I'll touch on those first. It's interesting with the public option is, I think when it was first trotted out during the lead up to the implementation or adoption and implementation of the Affordable Care Act was a non-starter from a political standpoint amongst health plans. And again, I'm sure everybody dialed in is well aware, but the sense was, how can we as insurers compete with a Medicare-like plan that can cap rates, can offer broader access, that is absolutely still the reality. Even fast forwarding here 10 plus years, there are still some of those fundamental concerns around. Okay, if a public option comes into an exchange or is brought into an exchange marketplace, it's going to be really hard for insurers to match that, again, in terms of affordability, in terms of some of the access guarantees. But there's been a lot of thinking by folks on this call and others, and I think there's also the recognition that whether it's at the state level or in discussions with the Biden administration, there are different permutations of the model, and there's a world in which there is a public option available on the for the non-group market that plans could maybe not compete with, but offer a differentiated product that maybe is higher priced but has some benefits that you wouldn't get in sort of a bare bones public option model. That's still, I think that's kind of a minority view. I think the sense is that it still would be really hard to compete with that, and that a kind of a standard public option model would be reason or give a lot of our clients, at least health plan clients, pause in terms of staying in or getting into new exchange markets. And remember, we've seen this evolution of the exchanges first coming online, some insurers getting on, losing their shirts on it, getting out. We've steadily seen plans coming back in, older and wiser. And I think the public option would definitely, counteract that and probably cause insurers to exit the market. In terms of the capped rates, I think that's a really interesting piece, because on the one hand, our health plan clients see that as, well, that's great. We've had a hard enough time, especially on the employer side, capping rates. And we kind of, as for the reasons we've talked about, when we're in markets where hospitals are calling us shots, we have to pay them essentially what they ask for, or some, small discount off of that. And it would be nice to have the government come in, and maybe not for all lines of business, but for some of our big ones, to be able to say, no, this is the rate, this is it, within, certain confines. The flip side to that, though, is there are two concerns. One is, okay, well, we cap rates, but then we as a health plan have to build that and manage that network. And what are we going to do if we're the ones that are now having to, go out and basically tell our members, here's your hunting license, right? Kind of just like the classic argument around Medicaid and the cost sharing requirements there, and then the low reimbursement and the ability to maintain networks, adequate networks. So that's one challenge. I think there's also just the reality of, this is kind of the, is it opening Pandora's box, or the, camel's nose under the tent of, okay, if they come in and we're going to let them now tell us the rates and cap the rates, what's going to stop them from coming in and more aggressively regulating other parts of our business? So I think that's another source of skepticism around at least the capped provider payment concept.
Great. Thank you very much. I mean, there's definitely a lot of considerations and trade-offs as we evaluate these options. This might be a question for Ovik, but I think anybody I'd like to hear from others as well. It could be argued, Ovik, that healthcare payers and providers should resist the emergence of a competitive healthcare marketplace and make competing on value central to their strategy. What are the challenges and opportunities of payer and provider buy-in to the concept of increased market competition? And I think you're on mute. You need to unmute. If we could get a tech person to help out.
Okay, now I'm unmuted. Yeah, I think I was muted more centrally. So a couple of things to say. First of all, the value conversation in general is one that, while there are meritorious ideas and a lot of good people working on value-based insurance design, value-based outcomes in provider settings, et cetera, one thing that's really important to understand about the value conversation is that value is not the same thing as price. People can define value differently. They can define relative value differently. You could pay 3x for a good outcome and 1x for a bad outcome. I mean, excuse me, 3x, yeah, 3x for a good outcome, 1x for a bad outcome. But if 1x is already a very high, unaffordable price, then the net result is more healthcare spending, not less, right? So it's what you describe as, if the point of value-based care is to say we're going to pay you more for a good outcome, or we're going to pay you less for a bad outcome, those are relative descriptions of the price you're paying, and what matters is the absolute price that you're paying. So unless we get the absolute price and absolute spending of healthcare under control, the impact of value-based care on affordability is uncertain, and in fact, they're effectively independent variables. So that's one thing I'd want to highlight. The second point, in terms of the incentives, as implicit in your question, Kate, is that a lot of the providers are not participating in value-based arrangements, and this has been a huge problem. And a big part of why is because if you're a hospital, what incentive do you have to get paid less? Because the way payers are trying to do value-based care is, we're going to pay you more relative to the standard rate for a good outcome and less relative to the standard rate for a bad outcome. And that less part is not particularly attractive to providers. So what we've seen, for example, in Medicare demonstration projects is what wonks call one-sided risk, where you get the upside if you're the hospital if you get a good outcome, but there's no penalty for a bad outcome. Getting hospitals to adopt two-sided risk has been a lot harder, because that would mean less money for the hospital. So you'll hear a lot of people say, hey, it's great, we're seeing a lot of adoption of our value-based contracts, but when you look under the hood of what's in that value-based contract, it's basically meant to pay hospitals more for a good outcome, but not less for a bad outcome. And so it's really important to kind of dig into that and get more. We need to push harder if we want to do value-based care on that two-sided contract where there's a risk reward for all parties. I do want to address a little bit this point about how if we had some sort of external ceiling to prices, that would basically blow up the private health insurance industry. People who participate in Medicare Advantage would be very surprised to learn that ceilings on reimbursement rates blow up the private health insurance industry. In fact, in Medicare Advantage, we do have ceilings in the form of Medicare's fee-for-service reimbursement rates, which effectively are a kind of cap on what Medicare Advantage plans pay. They can pay more if they want to, but they're not forced to, because basically the hospitals have to accept that Medicare standard fee-for-service rate as an alternative to the negotiated rate if the payer and the provider don't come to an agreement. And that has turned out to be a really successful model. In that, in the MA case, dozens of plans are competing with each other all the time, robustly. There's robust competition among private plans. It's a very attractive market for payers, and yet there is a governor on monopoly behavior by hospitals, because they basically can't really consolidate and charge 3x the Medicare rate because payers don't have to accept that rate. So that turns out to be a pretty attractive solution. We might call it Medicare Advantage for All as a reform platform that could be adapted for both the employer market and the individual market that's now regulated by the Affordable Care Act.
Very good. Did anyone else want to jump in on that question before I move on to the next?
Okay. I would like to just add on the point about value-based care, that how we define value is sort of, has been, including in many value-based payment arrangements, has been, based on what the system has decided is most important and not necessarily what people have decided is important. And a lot of, I think, value-based care arrangements that even get tagged value-based arrangements are ultimately just, bonus payments for fee-for-service, payment. And, doesn't really have any true benefit to people or in any way kind of start moving the dial in terms of how people experience care. So I think when you think about competition in the context of value, again, it's really important to understand better what people are actually looking for from health plans, what they're actually looking for in terms of their experience, whether it's a hospital system or a provider setting, because oftentimes what gets decided with CMS or any given health plan about what value is and what's going to be prioritized is very much through this lens of how do we get costs down, how do we move the dial on a range of important quality metrics, and completely misses the point in terms of what's important to people.
Thank you. I'd like to ask a question, since we were just discussing, as someone mentioned the employer market a few minutes ago. There's a question from the audience. A public option in the employer market could destabilize the employer group. Some groups might not then meet participation requirements if their employees are opting out and into the public option, and the plan would unwind. Isn't this a slippery slope to single payer? I don't know who would like to take that question. Perhaps Emily or John?
I might step in and, while other people are formulating their answers. I mean, it's not necessarily a slippery slope to single payer. I mean, if you have a public option, if it sets rates at, say, let's say there was a public option in the commercial market that said we're going to pay 150% of Medicare rates or even 100% of Medicare rates, and that's going to be the public option. The private plans are going to then say, you know what, hospitals, we've got to get paid, or we've got to pay you at similar rates to the public option plan, or we'll go out of business. So, which is kind of what happens in Medicare Advantage today, right? So Medicare Advantage is gaining share relative to fee-for-service. The CBO projects by the end of this decade, a majority of seniors will be on Medicare Advantage plans, not on traditional single-payer Medicare plans. So if that is a proxy for what we might expect in the employer market under similar conditions, we should have more confidence in the ability of private plans to compete. Now, obviously, a lot of it would depend on exactly how the private option, public option was structured. If Congress created rules that unfairly advantage the public option relative to the private employers, the employer-based plans, excuse me. But to say as an absolute fact that if there's a public option, the private insurance market will collapse, there's not a lot of evidence of that.
Can you hear me?
Yes, John, thank you.
Oh, okay. Yeah, I agree with an awful lot of what Alex was saying, particularly with respect to Medicare Advantage. I don't think all employers would choose the public option, even if it was less expensive. There are certain advantages to them to tailoring benefits, cost sharing, networks, or whatever that might have real value to their employees. And I think it would be likely to be attractive to smaller, lower wage businesses, providing them with a much better option than they have today. It's not completely clear to me that it's a better option than larger employers can get on their own. The other point I'd like to make is that public options are in the non-group market. A public option is not going to wipe out other insurance plans in the more competitive market. Because they have really negotiated payment rates down to pretty low levels already. And in the work that we've done, we don't see the public option, having major effects in the competitive market. It does have a big effect in where the markets get more concentrated, and that's what you want.
Mm-hmm. Very good. Thank you so much for that. Yes, go ahead.
Oh, sorry, yeah, and I just wanted to jump in on the public option in the employer market and would it destabilize? And yeah, I think it's a great analogy, although a little bit different, but the Medicare Advantage piece and recognition that there's still very robust competition there. I also, I would just echo John's point that, and we already, again, it's not completely analogous, but there was always the fear of when we have these exchange plans, are we going to see employers just dumping employees onto the exchanges? And there was some of that. I don't have the stats in front of me, but it was not this sort of tidal wave of folks out of the employer market. And in fact, that the employer market is still very robust. And I do think that, for some big retailers, for lower income, lower wage workers, this may be a better option and better option for the employer. But all the work that we've done, particularly with employers with large sort of white collar workforce, this is a differentiator for them, and they would not say, oh well, guess what, we want to hire you and you get to go on the public option. That's a non-starter. So I don't think, you really have to kind of segment that employer market and really understand the dynamics across the different employer types, employer sizes as well.
Okay, thank you. I want to ask a question. This might be for John, although some others may have a perspective as well. Could you go into strategies targeting private insurance costs in rural areas?
I think that's hard, and it's one of the reasons we did a paper that said, well, what if you introduce some of these options, public option or capped rates, but exempted rural areas? Because it's hard to attract providers. A lot of hospitals have pretty serious financial problems, and that may not be the place you want to go. They are pretty concentrated markets, and they are higher cost. But there really is a risk of losing what you have there. And so the thing I would add that makes it a little more complicated is that rural hospitals, at least, are mostly Medicare and Medicaid. So even if you constrained through a public option or capped rates what commercial plans are now paying, the effect would be muted because a significant share of the hospital revenues are already coming from Medicare and Medicaid. So the effect is less than you would see in urban areas.
Mm-hmm. Thank you. Does anyone else have a perspective on rural areas and consumers who live in rural areas and their ability to access affordable coverage?
Yeah, so in our proposal at FreeOp, we exempted the rural hospitals for precisely that reason. There obviously is not going to be a lot of, you're not going to have 10 hospitals competing to serve a rural population. And so in the Hospital Competition Act and the Fair Care Act, which are reflective of our proposal, we basically exempt rural hospitals from the threshold of where we try to incentivize competition. What the Hospital Competition Act proposes is among urban or suburban hospitals, if the market concentration is very, very high, basically 2x or actually really 4x the Federal Trade Commission's normal threshold for getting involved in antitrust litigation. At that point, hospitals would be expected to use the Medicare Advantage rates, accept Medicare Advantage rates from an employer, or divest some of their hospital systems to restore a competitive market, in which case that threshold would no longer apply. So basically what we try to do there, that detail is really important, is we try to give hospital systems an incentive to disaggregate and voluntarily design more competitive markets, as opposed to simply saying, if it's consolidated, we're just going to regulate prices. Instead, we say, if you're a CEO and I'm a CEO and we're thinking about merging our two hospitals, we know ahead of time with great clarity that if we merge, we'll go above that threshold, and then we won't be able to exploit our merger, our greater market power to charge higher prices. Instead, we should stay separate, because if we do so, we would compete against each other in a market and have to compete quality and outcome and value that we're providing patients.
Great.
Yeah.
Thank you.
And sorry, I would just add, again, bringing in the Medicare Advantage angle on this, Ovik's right that Medicare Advantage plans are absolutely capturing share. When we do the math on this and we look at, Medicare Advantage penetration, it's those rural markets that are really kind of the standouts there, and where when you look on a county by county basis where there's one plan, right, as compared to the urban and suburban markets and counties where there's a lot of competition. And I think that's just a reflection of the economics are tough. You're dealing with a true monopoly. The other piece of this that I would just touch on is that, you don't want to undermine access for rural markets that are already, many of which are struggling. And it's also the case that the hospitals are almost invariably the biggest employers, right? So there's a political component to this. It's not just they are the healthcare provider, they are the employer and maybe the last remaining kind of, private employer in a lot of these markets. So that's touchy. You don't want to undermine that.
No, we have definitely seen the impact of politics on healthcare all around, but very much in that realm, we realize that that they are large employers and can dominate in an area.
Can I just add that?
Yes.
Just an important point, which is that in many of the states that have not expanded Medicaid, those states have a lot of rural areas in them, and so you are a part of the struggle for a lot of rural hospitals is that they're not getting revenue that they would otherwise get through the Medicaid expansion. And I think the point that John made here and made in his paper around rural hospitals is a really important one that should also extend to other medically underserved areas that are not, technically rural areas, but places where you have systems and providers that are likewise financially struggling, don't have the same kind of assets, don't have the same kind of revenue diversification, and are predominantly serving low-income communities. So thinking carefully about those kinds of areas as well in the context of a private option would be really important.
Great. I'd like to ask a question that came in about technology assessment. How can value assessment and health technology assessment play a role in reducing costs? And not just for prescription drugs. What are the other ways in which we can use assessment mechanisms to reduce costs? Who would like to take that question? It's one.
Well, I mean, I would just say, in theory, private insurers can do that, right? There is one of the kind of dynamics of our system is because there's an employer-based system where workers are not necessarily exposed directly to the cost of care. The insurance company gets blamed if they say, no, we're going to not cover that treatment or that particular device because it's not cost effective. And the more you move to a market in which people are choosing their own health insurance, they're able to make those choices themselves. That happens in MA to a degree, that happens in the individual market to a degree, and that should happen more in the employer market if we were able to migrate the employer market into one where gradually over time, more and more workers have sovereignty over who the issuer of their health insurance plan is. There was a rule enacted during the Trump administration called what we call the HRA rule, allowing employers to use health reimbursement arrangements to give workers the money to buy non-group coverage instead of employer-sponsored coverage. I'd encourage more employers to use that model so that way individuals can decide whether they want to go with a plan that draws a tough line on costly treatments, or whether they want something that covers everything and they're willing to pay the higher premium for it.
Mm-hmm. Thank you. This might be a question for Fred, since you mentioned it in your presentation. In light of the new transparency rules for hospitals and insurers, do you think employers may be interested in using this information to pressure their insurers or TPAs to negotiate better rates for their plans?
Yes, and in fact, it's very on the nose or on target. We are doing work right now with employer groups in a few different markets who, and as I said, we're the nerds out there like digging around trying to find this hospital pricing data. We're I guess the initial consumers of it, right? And what we're helping to develop are we're fusing that data as it's becoming available with, we have claims data so we can look at utilization and cost. And I promise I won't nerd out on this, but then also taking all the quality data that we have access to really try and give as broad a view of value. And Ovik, again, I think it's a good point. Value is a very subjective discussion or topic, but that I think that is the intent of, or one of the beneficial offshoots of the price transparency efforts is not only arming consumers, which we can argue about whether consumers can make sense of that data or not, but certainly employers, self-insured employers are going to use it. I think the one challenge is, and this is no slight at employers, but even at the largest employers we work with, 1,000+ FTEs, employees, they have 3 or 4 HR folks who are really focused on this and managing their network, and their kind of literacy and understanding around this data and how to make decisions is very limited. And so you're right, they're leaning on brokers, they're leaning on TPAs to help set these networks. So, I don't want to pretend that all this additional data is really going to transform it, but it adds very valuable insight and kind of rounds out the picture, starts to round out the picture on which hospitals are actually delivering value for the prices that they're getting paid.
Thank you. And I'd like to remind our audience that if you have a question, to please, this is definitely the time to submit it. We've had a pretty good discussion, and I want to make sure we have everyone's questions here. This next question, I think almost all of you may be able to address. Is it fair to assume that all stakeholders in the healthcare industry, and I would add patients themselves, the regulators, the providers, insurers, employers, and definitely patients, perhaps acting as consumers, have roles in creating competition? What are the key roles of these different entities, and how do we incentivize action?
Well, just to double down on what I said before, I think that if you want a competitive system, if that's what you want, not everyone does, but if you want a competitive system, you've got to put more control over healthcare dollars in the hands of patients. Right now, patients are totally removed from the equation because even if you have employer-based coverage, that's theoretically private sector coverage, but 80 cents of every dollar is being spent by the insurer, not the patient. And the employer is choosing the insurance plan, not the patient, not the worker, not the consumer. So you've got to move to a system in which people are choosing their own insurance plan. That's the only way to incentivize insurers to compete with one another on cost, and thereby for providers and drug companies to compete with each other on cost. So unless the patient's doing that, the government's going to step in and do it instead. Those are basically the only two poles, and we've kind of got the worst of both worlds in the U.S.
I think this would be, first of all, I don't think you can, to Ovik's point, I don't think you can, I guess a different angle on that point, separate this question out from just the reality that everything's so expensive. So you're talking about, given the struggles that people have today with affording out-of-pocket costs, with a relatively limited amount of money for any given average American in terms of how they can leverage their own dollars to promote competition. I would also just point out that, the purchase of health insurance is so complicated, the system is so complex that people, generally speaking, really aren't interested at this point in shopping because it feels like they can't figure anything out. So I think first and foremost, it does reinforce the important role of consumer assistance and making sure that there are resources available to help people make decisions about what's the right healthcare plan for them and is in line with what they can afford. It also speaks, I think, importantly to the value and importance of figuring out a systems approach that does work better for people and is fundamentally, on some level, easier for anyone to figure out. As I was sort of explaining at the top of the call, I think even people who work in healthcare and who are privileged with time and money find it very difficult to navigate when they get surprise bills or to figure out what actually is covered versus not covered on their own plan. So that to me is one of the biggest barriers to giving people a space to promote competition.
Can I just add to that a little bit?
Yes, please do.
Yeah, I agree. I mean, I think putting money in the hands of people, that's been going on for a good long time. The deductibles have gone up, to pretty high levels, to the point at which people complain that we have huge affordability problems because of high out-of-pocket costs. If that was going to work, we wouldn't have the problem that we're all here kind of talking about is the very high cost of healthcare in this country. We're really dealing with monopolists in the drug industry, as Alex talked about. But we all talked about monopoly power in the hospital industry, and hospitals buying up more physician practices. And that's where the problem is. The individual consumer can do very, very little about any of that.
If I could just respond to that point, I'm not saying that we should just leave people exposed to high costs without any resources. What I'm saying is the subsidies in our system go to insurance companies and government-sponsored insurance. They don't go to consumers. What if we actually put more of those dollars, again, in the hands of patients? Then they would have the resources to pay for those out-of-pocket expenses. We basically steer people to have third-party and fourth-party and ninth-party payment systems because that's where all the subsidies go. The subsidies don't go to the consumer to pay for things. They go to the insurer to pay for things or for the government to pay for things.
Yeah, and I know
even if they had that power, I don't see how they can, the monopoly power in healthcare is really the problem, and I don't see how, whether it's through subsidies or not, that giving individuals more say over what they use and where they go for care or whatever is really, there's any evidence at all that would make much difference.
Well, I want to thank all of you for your insights on this topic. Something tells me, based on the number of questions we had come in and here and your perspectives here, that this is not going to be the last discussion on this topic. So we look forward to engaging with all of you and with our audience going forward. I want to thank all of our panelists for joining us this afternoon. And to our audience, please take time to complete the brief evaluation survey that you will receive immediately after the broadcast ends as well, which will also come via email later today. We really value your input and it does impact our programming. A recording of this webinar and additional materials will be available on the Alliance's website. John, Ovik, Fred, and Emily, thank you so much for joining us. Have a great day.